that, a physician or a doctor or some kind of clinician is looking for or talking about when they're speaking about major depressive disorder or clinical depression. I want to talk about some of the treatment options that are available, some of the resources that are available within our network, including some that, maybe a few of you don't know too much about, like transcranial magnetic stimulation, the partial hospitalization program. And at the very end of our talk, like Becky said, we'll have a question and answer session. So my understanding is that there is a chat. So if at any point you feel like you have a question, you want to jot it down, put it in the chat. That's something that, we'll try to address at the very end, certainly. I also think that there's going to be an opportunity to speak into, so if you feel comfortable doing that as an alternative, you can do that. All right, so let's keep going. So some of the learning objectives. One is I obviously want you to come away with a better understanding of clinical depression as well as its risk factors. I want you to be aware of the different treatment options available to you. And I'm going to key in on some of the two very specific treatment options, including transcranial magnetic stimulation. And you may be thinking when you're, listening to me, is this right for you? What should I try before I even get to TMS? How does this whole process work? What does it look like? And how does TMS differ from some of the other non-invasive treatment interventions like or procedures like ECT? And so I'll have a slide where I can go over those differences as well. And then, I'd be remiss if I didn't include a wonderful, wonderful resource like the Partial Hospitalization Program, which I think offers a lot of support and resources. And I couldn't speak higher about the Partial Hospitalization Program. All right, so let's continue on our journey. All right. So I always find that it's helpful to give some background information before we jump right into it. I said very early on in the presentation that this is a very personal and important subject regarding clinical depression, and it's important because it's frankly it's very common. It's too common. And so inside the United States, the 12-month prevalence is about 10% inside the United States, 1 in 10. And then over the course of someone's lifetime, the prevalence that or chances of that they have of experiencing depression is 21%. And so I think that this is incredibly relevant for people maybe that are here, but also if you can imagine a household of 5 people, it means that somebody, either you or somebody close to you, is struggling and sometimes in silence with symptoms of depression. And so, we're gonna talk about what possibly we can do about that. The average age of onset for depression is 30 years old. It approximately occurs 2 times greater in excuse me, females than males, and it's something that causes a pretty significant impact. I mean, life expectancy is about 7 to 15 years shorter for those who have untreated clinical depression. 7 to 15 years. 7 to 15 years. And so it's a pretty measurable, meaningful impact on someone's life and on our community. Let's keep going. So, all right. So I like this slide because it's very general, and it also gives for those of you who've come to today's talk an idea of what clinicians are looking for when they're talking about clinical depression or major depressive disorder. And so you need to have 5 or more of the following symptoms that persist for 2 or more weeks, and they cause pretty significant distress or impairment. And so naturally, it could include depression or something called anhedonia, where you have a pretty significant loss of interest and pleasure in doing things that you typically like to do. But also can affect your appetite, your sleep, your energy level, your concentration. It can result in reduced self-esteem or feelings of guilt. It can make you actually move physically slower or look really restless and fidgety. And, when depression is very severe, it can also result in suicidal thoughts or thoughts that just life isn't worth living. And I wanted to give you an idea of, again, what a clinician is looking for. So they're looking for 5 or more of these symptoms. And this brings me to my next slide, and I'm going to kind of toggle between these two slides, okay? So I wanted to say that depression is complex. It's not simple, okay? And what I mean by this is that someone can arrive at clinical depression for any number of reasons. They could be experiencing stress in their work life. They could be experiencing stress in their home life. They could be experiencing significant complicated grief or loss. They could have a history of trauma. They could have things that exist outside of depression, like anxiety or perhaps chronic pain and a slew of other things, perhaps even a primary sleep disorder. This is something that I sometimes go over with my patients who struggle with profound insomnia and maybe have an underlying sleep apnea. Sometimes they have disrupted sleep. Sometimes that results in fatigue or disturbances in their concentration. And then if you're not sleeping well and you have low energy and you have poor concentration, it can obviously affect your interest and it can obviously affect your mood. And so boom, you have five things right there. And so I want to go back to this slide. Depression is complex. It's not simple. And so you can arrive at this from multiple different avenues. And I bring this up because though there are certainly commonalities between a lot of our stories, there's also a uniqueness there. And I think in order to treat the individual, you have to be able to treat the individual and embrace and engage that kind of complexity and uniqueness. I think that's important. All right, so let's move forward. So now, what are some things that we can do to treat clinical depression? So some things are like promoting good sleep. Like I brought up an example earlier about, obstructive sleep apnea and how that can affect those struggling with depression. Well, we want to make sure that you're sleeping well at night, because that is essential to promoting your functionality and your mood and a slew of other things, physical as well as mental health. Um, we want to make sure that you're getting some adequate exercise. I think, I'll share with you even before this lecture started, some of the, my colleagues here, we were talking about the importance of getting outside and being able to take, sometimes a little bit of a break and perhaps a little bit of walk as the weather is getting a bit warmer. Making sure that you have a good diet, well balanced, healthy. That's important. So a lot of things that you hear from your doctors, a lot of things that you just talk about in general, all those things are important and they can't be discounted. All right. So then what are some other things? So there's medication management. And for that, we have a number of different medications that are very effective for treating depression. Sometimes they work really well and sometimes they don't work so well. And we'll talk a little bit more about that later. Sometimes we'll use medications to augment on top of our antidepressants and they can kind of boost the effect. And then there are other things too, which I think are incredibly valuable and also engage in the complexity and uniqueness of the individual and can kind of, they have a certain flexibility to them. And those are things like psychotherapy. Okay. I included here a couple of very popular and common and effective varieties of psychotherapy, which are commonly practiced for treating depression. And that includes cognitive behavioral therapy and dialectical behavioral therapy, but there's many different kinds of therapies out there. And these are two that I happen to like because I know that they have broad utility to those who are struggling. Some other treatments include neuromodulation, non-invasive procedures like transcranial magnetic stimulation, which I'm going to talk about, as well as electroconvulsive therapy, which I'm also going to talk about briefly in comparison with TMS. Okay. These are some services that are offered to those, inside the network that we offer here at the network. So we offer medication management, we offer psychotherapy, both for the individual and group. We offer TMS, we offer ECT. We have multiple different kinds of settings, including our outpatient group practices, our mental health clinics, as well as a partial hospitalization program, which is a kind of intensive outpatient program, as well as our inpatient program. We have that as well. So let's see here. We'll keep going. All right. So this, I think, is a useful slide. So for those of you who've come to join me today, you may be somewhere along this progression. Maybe you've come here for some general information and you've already met with your family doctor, or maybe you haven't yet. Maybe you've met with a psychiatrist, maybe you haven't yet. I don't know. And perhaps you're just looking for some general information about antidepressants and you haven't started one yet. And so commonly an antidepressant will originally be started, very early on in treatment, and it will usually include a medication from a class called SSRI, selective serotonin reuptake inhibitor. And these are a very nice class of medications, not because they're superior in effectiveness relative to others, but because they generally have a mild side effect profile. So they don't really usually cause too many side effects, although they can. Um, and they are effective. And I would say probably those trying their first SSRI, I would say about 30 to 40% of the time, it, it results in a very positive outcome, complete remission of symptoms, or very significant partial remission of symptoms. If that doesn't work, and that happens sometimes, as I said, 30-40% of the time it works. That means that all the other time it doesn't work as effective as you would want. It means that you switch probably to another antidepressant. This is very, very common. And so your clinician may try another SSRI, or maybe they may try another class, like an SNRI, a serotonin norepinephrine reuptake inhibitor. And then I would say about 30% of the time, this second try is effective. But again, that means that there's some people out there that are still struggling with depression. And then that could mean another trial, and that could mean eventually you're augmenting. And every time you move down that progression, um, the chances that the next step will be effective goes down. Okay. And so some of you in the audience may personally, or perhaps somebody close to you, have tried multiple medications and they either didn't find them adequately effective, or perhaps they didn't tolerate them well because they were experiencing side effects. Who knows? But what are your options available? Okay. So I'm going to use this as an opportunity to talk about what is treatment-resistant depression. What does that mean when somebody says treatment-resistant depression? So there's actually no universal definition for this, but it commonly means that you've tried at least two separate trials of antidepressants. So to go back to this previous slide, it means that you've gone beyond that step 1 and step 2, and now you're in step 3, step 4 at least. And that's commonly what is meant when doctors or nurse practitioners or physician assistants or your therapists are talking about treatment-resistant depression. And so what can we do for treatment-resistant depression? So I know I've been talking about it. I know that this has probably come up, very early on, and maybe it was included in the pamphlet that you read. Transcranial magnetic stimulation. So this is a non-invasive neuromodulation procedure, okay? And it is reserved for people with treatment-resistant depression. Those of you who have failed two medications, have tried therapy, and nothing seems to be working or not working well enough. And so what is TMS? TMS is a non-invasive procedure. It uses actually an electrical coil that pulses. And when that electrical coil pulses, it creates a magnetic field. And that magnetic field is a similar intensity of that of an MRI. And when it pulses, it actually stimulates nerve cells in your brain. And it improves symptoms of depression when it's targeted and used appropriately. And so I'll talk about that in a little bit. So TMS is not ECT. It is not electroconvulsive therapy. ECT was created in the 1930s, and it uses actually a direct electrical current to the brain and induces a seizure. There are no, induced seizures in this case, okay? Nothing, we don't aim to give you a seizure. Now, TMS had an FDA approval and has been approved by the FDA for many years now, for 14 years. I'm doing the math right. Since 2008. And since then, there have been 4 other devices that have been approved for by the FDA. In 2013, the FDA approved TMS for certain types of pain as well as migraines, and research goes on. And in fact, there's a recent research study that's happening in Stanford that uses repetitive TMS, and it's very, very exciting. But more on that later. So this is, I think, a fun picture. I mean, I say fun, but I'm a psychiatrist, so maybe it's not fun for you. But I think that fun is maybe not the right word, but interesting. So on the one hand, you have a picture of a brain of a non-depressed person. And this is a PET scan. So this is looking at metrics that correlates for brain activity. So blood flow, oxygen, blood sugar, metabolism. And you see a lot of activity on the left-hand side of a non-depressed brain. And then you have significantly less activity. It's kind of hypoactivity for those that are struggling with depression. And so that's what we're trying to do when we use TMS, is we're trying to, again, use a kind of magnetic field to stimulate very specific areas of the brain that are hypoactive. And by activating it, we're relieving some of the depressed feelings or symptoms. Let's keep going. All right, so what does that look like? So that magnet that is created by that electrical coil that pulses stimulates a frontal portion of the brain called the left dorsolateral prefrontal cortex. And this is an important part of the brain for concentration, for working memory, as well as for depression. And if you can imagine this complicated network of, really innumerable, infinite nerve cells that are communicating with one another, by stimulating that portion of the brain, you're also stimulating other portions of the brain that are implicated for depression, like the anterior cingulate gyrate, striatum, the hypothalamus, the hippocampus, the amygdala. And so this is how TMS works, is it uses that magnetic pole to stimulate nerve cells in the brain that are implicated for depressed patients. So how does it work? This is kind of reiterating what I just said, and I don't want to kind of bore you, but we're stimulating the left dorsolateral prefrontal cortex, and we're trying to increase the activity in regions of the brain that are hypoactive when you're feeling depressed. And we're using high frequency stimulation. So how does TMS differ from ECT? So a lot of ways, actually. TMS, you're going to be experiencing 30 to 36 treatments, okay? And it happens Monday through Friday. Commonly a lot of my patients will come, early in the morning before their workday, or at the very end, after the workday, or sometime during lunch, possibly, something like this. And each session, except for the first one, when we're mapping, or so-called mapping, and we're trying to find how to position the magnet appropriately so that we're really targeting the region of the brain that we want. That first session lasts for about, an hour or so, but every subsequent session lasts for about 18 to 20 minutes. And during treatment, there's going to be 3,000 magnetic pulses that happens per session. 3,000. You're awake throughout the entire session. And there are side effects that you may experience. Full disclosure, you may have some, there are loud noises, so you wear ear protection during the treatment. You may experience facial pain, headaches, a twitch, but those are symptoms that only happen during the treatment, and they usually are only experienced very early on as you're adjusting to this new intervention, this new treatment. Usually by the end of the first week, people are very comfortable, and the symptoms are always very mild regarding the headache, facial pain, things of that nature. And if it is ever too uncomfortable, then we can stop the procedure and we can kind of try to reposition the machine to try to mitigate those side effects. Now, what happens during ECT? ECT is about 6 to 12 treatments, and they last for about an hour. And so usually the schedule is either kind of Monday, Wednesday, Friday. During the treatment, there's a burst that lasts for about 5 to 10 seconds, and it requires you to be under general anesthesia. So it requires sedation, okay? And you're going to experience electrical currents that stimulate rhythmic firing of your neurons that cause a seizure throughout your brain. And this, I'm not going to, my job is not to, to badmouth or, to belittle this treatment, because this is actually a very effective treatment for depression, and it works very, very well. However, some people don't want to, be treated for their depression by inducing a seizure, and they're looking for maybe some other alternatives. And I think that TMS is a very wonderful treatment. People will experience memory loss, jaw pain, headache, and I think a very important distinction here that's not on the slide is that those who have a seizure induced, you're not doing anything that day, okay? And usually you're kind of, you remain in the hospital, or certainly if you leave the hospital, you have somebody that's driving you back and forth, okay? But the majority of patients remain in the hospital during that whole treatment process. For TMS, you're never under general anesthesia. You can come and go immediately after. You can drive yourself to the clinic, you can drive yourself back home or to work afterwards. So I think that's a very, very important distinction. All right, so what are the risks of TMS? So some of them I've went over with you, including, possibly ear pain or hearing loss, which is mitigated by us giving you some earplugs and ear protection. Headaches, facial pain, those are the common side effects. I will say the rare, but more severe side effects is there's a very, very remote chance, a fraction of a percent, a fraction of a fraction, that you could have a seizure. That it has never happened at our clinic, and we've been running TMS now for 4 years. But education is the best prevention. So, it's important to keep your brain active. It's important to take your medications. Don't change your medications. If you drink caffeine, continue to drink caffeine. Limit your alcohol use and get a good night's sleep. These are important things that you can do to kind of maintain good, healthy brain activity and mitigate the risk of this kind of problem, certainly. All right, so what's the research to support TMS? What do we know about it? So there's numerous studies out there. There are numerous meta-analysis of randomized trials that found repetitive TMS to be superior to placebo or sham. Okay, so we know that this is effective. Some studies have shown nearly half of patients have had meaningful response to TMS, meaning 50% of their symptoms have reduced. So they had a very, very significant, robust response, or they've had complete remission of symptoms. Other studies in treatment refractory depression populations revealed lower responses. So this generally happens when somebody is struggling with multiple different psychosocial stressors, multiple different stressors in their life, socially, in their past history, who have tried many, many medications. Usually by that stage, there is a kind of lower response rate from those kinds of patients. Generally, the people that respond best to TMS are those that are still, I will say, relatively early on in treatment. Perhaps they've had, four medication trials, or certainly more than two, but in that ballpark. They have a tendency in general to respond better. Majority of patients experience sustained remission at 6 months. Follow-up. 35% of people did relapse and did require adjustment to their medication or a second round of TMS, which that happens sometimes. Sometimes people find TMS to be a wonderful intervention that helps them, but then some of the symptoms start to come back at 6 months, in which case they can decide if they want to address things through medications or if they want to try to revisit TMS, and a lot of them do. There are relatively low side effects, low adverse effects, and a very low dropout rate because of this, because the side effect profile for this is very mild. Okay, why do TMS? So alternative treatment to medications, and in addition to the standard antidepressant medication treatment. So for treatment resistance occurs in nearly half of all the patients. And we kind of went over that when I was going through the progression. And so for those people who are still struggling, what are their options? They can continue trying another medication trial, or perhaps they can think about doing something else. Naturalistic findings in clinical practice have found a 58% response rate and a 37% remission rate of all symptoms. This has been maintained 62% of the time over the course of the year. So some studies have shown that, which is very nice. Rescue TMS therapy found to be effective in 60% of cases where depression occurs. So for those people who do have those symptoms return, about 60% of the time it's found to be effective, that second round. What do patients say? So some of the positives, and I'll give you the positives, I'll give you the negatives, I'll give you everything. But positives include, I wanted to try something different. Nothing else worked in the past, and I didn't want ECT. People were very kind. Some people had a very robust response, no longer depressed. Some people without treatment, I don't know where I would be. It changed the way I think. The negatives, the travel. So it's 30 to 36 treatments, so it's kind of like almost a 2-month commitment of time. And each session is about 20 minutes. Some people had a lot of anticipatory anxiety and anxiety about treatment. They felt nervous. There was a headache and temporary facial pain associated with the actual treatment. It is expensive. And sometimes, especially if insurance doesn't cover it, and I think Becky will handle questions regarding that, if you have any, certainly. Some people said there wasn't really too many negatives, some discomfort during the treatment, but as I said, a lot of times that's mild. Some extra things. So shout out to some of the staff. Audrey is one of the nurses here. She was wonderful. She is wonderful. All staff was friendly and compassionate. My family could see a big difference. So I think that that's also noteworthy. Sometimes we don't notice the change within ourselves because it's happening, kind of gradually over time. But sometimes our family and our loved ones, the people close to us who know us, are the first ones to pick up on the difference. It doesn't work for everyone, but it's worth a try when you've tried multitude of medications with no results. All right. So who is right for TMS? So as I said, people who with treatment-resistant depression. So people who have failed two medications, who have tried therapy, and that doesn't seem to be working. People who can make daily appointments that last for at least 20 minutes for 6 to 7 weeks in a row. And then, of course, there are other things that maybe would exclude you from this kind of treatment, including a history of psychosis, auditory or visual hallucinations, delusions, paranoia. And also because we're using kind of magnetic fields, metal hardware in your head and neck. So that include metal plates, coils, clips, stents, shrapnel, etc. What's a typical journey for those who are interested in TMS? If you are interested, I would suggest you bring it up with your family doctor or your psychiatrist and figure out if you're appropriate. And if they think you are, then you can obtain a referral to meet with me or one of the other psychiatrists at the clinic for a TMS consultation. And during the consultation, you'll get a complete psychiatric evaluation. We'll do a review of your medications, um, dates, dosage, how long they were, tried. We'll do a review of your history of psychotherapy. We'll look for anything that would exclude you or make TMS unsafe. And that includes a history of seizures, neurological disorders that put you at increased risk for seizures, metal hardware in your head and neck, like I mentioned before. We'll answer any kind of questions or concerns that you have. And at the very end, there's that kind of clinical component, but we'll introduce you to Becky in person. So you get to see her in person. And, she'll discuss with you insurance coverage, payments, scheduling options, things like that. On that first day, if you feel, all throughout those points, you're appropriate for TMS. So then on that first day lasts for about an hour, sometimes a little bit more. And we're looking to try to position the magnet accordingly. And then that takes a little bit longer. And every subsequent session lasts for about 20 minutes thereon. And that goes on for about, 7 weeks or so. Most people stay on their medications for depression. If you're on medications, it is our recommendation that you remain on those medications. So where can you find this? So we'll include this information at the very end too, but this is where, we operate, on Shonersville Road. And this is our phone number, and this is our email if you're interested in it. And we'll put this up again at the very end. Some of you maybe aren't interested in TMS, in which case I want you to know of another wonderful, wonderful resource that we have inside the network. Okay, and so that's the partial hospitalization program. And so it says patient here, but forgive me, this is a typo. Partial hospitalization program. Okay, and so this is an intensive outpatient day program. So this is, if you can imagine, this is the highest level, of treatment that we can offer somebody who's feeling depressed in the outpatient setting, so shy of going to the hospital. And it's an intensive program that offers short-term support to help you achieve your individual goals. There you will identify and practice coping skills to manage stress and return to a successful life. And there's a wonderful team. We have two partial programs within the network, and they are comprised of a wonderful team of multiple different people. It's an interdisciplinary team that includes psychiatrists, nurse practitioners, physician assistants. Well, actually, I have a great slide. So instead of me saying this, let's put this up there. So psychiatrists, nurse practitioners, physician assistants, professional counselors, social workers, as well as other mental health professionals. And so everybody is pulling together, what they can kind of bring to the table, what they offer, what their skills are. And as a team. It's a very much a team-like approach. They try to provide support and help. And so it's useful to know about how, some of the kind of concrete factors or details regarding the partial program. So it operates Monday through Friday. It's 6 hours per day, and I believe it operates between 8:30 and 3 p.m., at least the adult program. Regular attendance is critical for treatment progress, and I can't stress this enough. Regular attendance is critical for treatment progress. We really want you to be able to attend and commit to the program, because we're talking about this short-term stay, and I believe the average length is somewhere around 2 weeks thereabouts or so. And so for that short period of time, we really want you to commit yourself to, working on your well-being, your mental well-being. And there's intensive group therapy, most of the day, and it comprises that. But sure, there are also opportunities for you to meet with your psychiatrist, meet with your therapist. Um, a length of stay varies for each individual, which is true, but the average, I think, is about 2 weeks. So topics that are addressed in partial. So many. Stress, anxiety, complicated grief, loss, anger management. You will work on improving interpersonal communication that you may feel is lacking in your relationships or relating to other people. Mindfulness, distress tolerance, relapse prevention, assertiveness training, working on your self-esteem. We offer 2 programs. And this is the information, this is where they're located, and these are some of the phone numbers. So I want to make sure that you have time, and if you're ever interested, you can reach out to us. And if you feel like you want more information, you can reach out to us. That's true too. And Stacy's here available, for any kind of questions that you may have at the end of the presentation. So what do people say about the partial program? Being with others who are going through the same things really helped. They validated my feelings and helped me move forward. Our situations may be different, but our problems are the same. The most important thing I learned is that we can heal. And I think that those were direct quotes, but really, there's so many people I feel that have gone through the partial program that would share that feeling, that sentiment. Okay. So these are some citations, based on that I use in creating this presentation. And I believe that's it. Oops. So now, we'll open it up to any kind of questions that you may have for me, for Becky regarding, coordination of TMS if at all you're interested, or for Stacy if you have any questions regarding the partial program. But thank you very much for joining me tonight. I know it's kind of an unusual time.
Hey, Dr. Doyle, it's Stacy. I did see one question come up in the chat. I don't know if anybody else has additional questions that they'd like to verbally ask us or put in the chat. The one question that did come up, one of the questions was about available therapy resources throughout the network. And I think, they're very limited. And I think Dr. Doyle really touched on this in the very beginning of his presentation when he talked about just how common depression is. Everyone is unmuted. I'm sorry, I want to just let everybody know that we have unmuted all the attendees.
Well, Sarah can go to bed.
So, if you'd like to mute yourself until you're ready to speak or ask a question, just so you're aware that there is that everyone's unmuted. So Dr. Doyle talked about, how prevalent depression really is and how common it is. And, that's not even talking about anxiety and panic and other kinds of mental health issues that people are struggling with, even more significantly now during the pandemic, right? So people who have been coping and functioning pretty well over the last couple of years have really engaged in some struggles because of the way life has changed. So the need for these supportive services has increased, I believe. And so the resources that we have just can't meet that need at all times. So some of our outpatient practices, it's true, they are not, they don't have availability to accept new therapy clients right now. But we have our psychiatric centralized intake. So when referrals are sent to them, if they'll review, and if we're able to schedule someone in one of our practices, we certainly do that. If not, we do provide resources in the community. One of the other things is that if you have primary care here in the network or see a specialist in the network, there are some embedded therapists through population health that do short-term brief individual therapy to help bridge people if they don't need longer term therapy. That may be an option. Again, you know, there's we do work collaboratively with some of the other agencies in our community. Sometimes if people are in need of more intensive therapy, when they connect with our centralized intake, they'll be referred to partial hospital program because it's typically a quicker access to not only more intensive therapy, but also psychiatric evaluation and assessment for medications. So that's another way that we can be involved. Wait list, there was a question about wait lists for partial hospital program. Typically, both partial hospital programs are able to schedule within a week or just a couple of days more than that. Sometimes I'm able to schedule somebody the next day, depending on what our situation looks like. So it is, we are really able to provide pretty rapid and, as Dr. Doyle said, intensive treatment here. And I'm happy to answer additional questions about partial, and I can be called during program hours. If you'd like to speak offline and not within this environment, our numbers are there. I can give my direct office number too. I'm happy to do that. If anyone would like that.
I have a question. Hello?
Yes, sure.
Yes.
Oh,
Go
go
ahead.
ahead. I
Go
wasn't
ahead.
sure if I was being, if I could,
Yeah.
you could hear me. Does the TMS, does it work at all on adult ADD? In addition to the depression, does it, I know that, when you were showing the slides, it works on the frontal, the front of the brain.
Sure.
Does that, have you noticed, or has anyone said that they've noticed any improvement in like the ADD part of, I mean, for me, it's like ADD and depression, and it's been that way for, 40 years, 40 years. But I'm just curious if, if you've heard anything about it working on that aspect as well, and possibly being able to maybe get off the Adderall and and just have a better grasp on things.
So thank you. I think that's a wonderful question.
Thanks.
I don't know whether I can give you the best answer or maybe the answer that you're looking for. I will say this. Right now, TMS is only approved for, treatment-resistant depression, not for ADHD. But you're correct in saying that I'd mentioned how, that region of the brain, the left dorsolateral prefrontal cortex, that's an important region of the brain for concentration as well as working memory, and is connected to a lot of other regions of the brain that are relevant to treating depression. I have seen some people tell me that their concentration has improved, but I don't know whether I would say that this is, sufficient treatment for ADHD. I think that if you're a person who has responded really well to a medication for ADHD, like Adderall or something of the like, then I don't know whether you'd be able to substitute it with TMS. I don't think we're there yet.
And I wanted to add into that as well. So it is only FDA approved right now. TMS is only FDA approved for major depressive disorder. We have seen patients who are being treated for depression. Once their depression starts to get better, it starts to affect all different areas as well. So we've seen it with anxiety.
Yeah, that makes sense. I mean, that if you it's kind of like the major depressive syndrome is the crux of it, and fixing that, or treating that, it just makes sense that it would sort of trickle down and work on other areas of your life, that you have difficulty with. So I mean, that makes sense. So I know I'm gonna check it out for sure. So
Thank you for the question, though. Yeah,
thank you.
sometimes it can be very difficult to tease apart when somebody is struggling with both ADHD as well as depression or possibly anxiety, because any of those mood disorders can obviously impact your concentration. And so there's a kind of overlap there. And so certainly some people will notice some difference, but like Becky said, and like was mentioned a few times before, really it has FDA approval for depression, not for ADHD.
They are working on, so we use the NeuroStar. They are trying to get different indications to start treating other disorders such as bipolar, anxiety. I mean, down the road, I do see this happening, but they have to do a lot of studies, and once that happens, they'll start trickling in. They're working on pediatrics. I mean, there's so many things that TMS can treat. But at LVHN, we are only able to follow FDA guidelines.
Same time, yes.
There was
Okay.
also a question, I'm sorry, there was also a question about a wait list. I know we answered it for partial, but I also wanted to answer it for TMS. There is not a wait list exactly. We do, we work with the hours between 8 to 4:30. So some of the hours are more popular than others. So if there was a specific time that you did need, we may have to push it out maybe a couple weeks. But if you were able to come maybe more towards midday, we have the availability to start. It also depends also for TMS when you can start with your insurance. Some insurances do authorize it immediately, and then other insurances take about a couple weeks to review, which we know all of how each of the insurances work. So you definitely can reach out to the office.
I have another question about insurance. I mean, I know it depends on your your insurance provider, but do you typically accept, okay, this patient has been on 3, 4, they tried different medications and therapies and all. Let's just go ahead and approve this, if it's something that they approve in the first place, or do they make you like jump through the hoops, like sometimes they do when you need to have a like certain imaging studies where they'll say, well, let's go with the least like an x-ray, compared to an MRI type thing. Let's start from the bottom and then work our way up, and once they fail, then we can approve this, this therapy or this procedure. Have you noticed that the insurance companies are becoming more, are they approving it a little more readily than they would have, say, a couple of years ago? Or is that something that,
Yeah, those are all really good questions. It honestly depends on the insurance. So
Okay.
One thing to be said right now is the only insurances that accepted right now and will pay for it is Medicare and commercial insurances. Right now, the medical assistance does not cover this treatment. But with that being said, every insurance is different. Some insurances only require one medication failure, and then other ones want to see 4 medication failures, augmented, that you've been in therapy. Everything's driven by the insurance company. So, I mean, you definitely can reach out to me tomorrow at the office. I can
Okay.
look at your insurance and give you a better idea of what your insurance would say.
Okay. Thank you.
You're welcome. All right. Well, I want to thank everyone for coming out tonight. Thank you, Dr. Doyle. That was a great presentation. And if anyone has any questions, you definitely can give us a call, email us. Our office phone number is 610-297-7500, as it shows on the screen. And Stacy, do you mind giving the partial phone number?
So that it's back up on the screen. The adult transitions partial here in Allentown is 610-402-5950. And our partial hospital in Bethlehem is 484-884-5690. Basically sister programs doing the same kinds of treatment modality, just on opposite ends of the valley. That's all.
All right. Well, thank you, everyone.
Thank you.
Have a
Thank
good
you.
evening, everyone.
Very informative. Thanks so much.